Hi everyone, this is the end of Neuro Chapter 28. If you listen to the other video, we stop right at CNS infections, and when I went back to listen to it again, the audio for hypotonic is like very far away, like you're listening to somebody in another room, and even if you crank the volume up, it's very difficult to hear. So we probably have about less than 10 slides left, so we'll just make a real quick video on it so it'll be easier for you to hear. So the hypotonic infant is a little one who is floppy. When picked up, they droop. We know with a normal infant, if you put your hand under the chest, then they attempt to hold their back straight, or as nearly straight as they can, have their arms flexed, bent at the elbows. A floppy infant will have a droop of the hand. These kids are alert, but they have depressed spontaneous movements. They may have had a history of abnormal in utero movement. There's a wide range of other symptoms that may be seen, excuse me, and these could include seizures, failure to react to pain, muscle wasting, absent reflexes. Causes for this condition usually focus on metabolic or CNS dysfunction or a systemic illness. If CNS involvement is noted, then it's usually a serious condition. These babies need to be referred to specialists, and including a geneticist. And the diagnostic tool of choice is an MRI, although sometimes there may be muscle biopsies ordered. These kids often don't respond well to treatment, and rehab can often help maximize their function. Next, let's talk about Reye's syndrome, which is encephalopathy often associated with a virus. Infrequently, cases can also be seen as a result of varicella or a nonspecific respiratory infection, particularly H. flu type B. Prodromal symptoms of this illness can include severe vomiting that progresses. You can have irrational behavior. There can be stupor, a coma. There can be apnea, fixed pupils, decorticates posturing. Management includes an immediate referral to the hospital with admission for supportive care. And about 70% of patients survive. Some have severe neurological sequelae, and infants are more affected than older kids. Moving on, let's talk about a tethered cord. We all know that the spinal column, the spinal cord attaches at the base of the brain and has a free end at the caudal space. This allows for freedom of movement with growth, activities, and skeletal changes. With a tethered cord, however, that caudal end is more fixed at or below the L2 level, and this can cause abnormal stretching and do damage to the nerve cells, the fibers, and the blood vessels. Symptoms can progress to show neurological deterioration. It's often associated with a congenital spinal abnormality such as spina bifida, seen with about 90% of the cases. But tethering can also result from bony protrusions, tough membranous bands, lipomas, tumors, trauma to that area. MRI of the spine is the gold standard for testing, and a referral to a pediatric neurosurgeon is indicated. Surgery is usually the treatment of choice and can halt or prevent any other neurological dysfunction. Next, let's talk about Arnold-Chiari malformation. Type 1 is a downward elongation of the caudal end of the cerebella vermis into the foramen magnum. And type 2 is a herniation that leads from the brainstem and the upper cervical cord and can cause compression and necrosis. The etiology is thought to be related to secondary disruption in the process of the neural tube closure. Type 1 malformations can have headaches, neck pain, atrophy, and decreased reflexes. Type 2 may include hydrocephaly, respiratory distress, syncope, poor feeding, vomiting, difficulty swallowing. Diagnosis is made by MRI. And one keynote with this condition is due to the risk of brainstem herniation, and LP should never be attempted on these kids. You always need to consult a neurologist, a neurosurgeon prior to those type of procedures. Next, let's talk about myelomeningocele. And this is when the posterior neural tube and the vertebral column have not closed. You have a protrusion of both the spinal cord and the meninges. The protrusion can only contain meninges, which is about 10 to 20% of the cases, or it can have both meninges and nerve roots, which are the remaining amount. The term spina bifida cystica is often used interchangeably with myelomeningocele. And when there's vertebral arch fails to close but there's no herniation of the cord or the meninges, this is called spina bifida occulta. And most cases of spina bifida cystica occur in the thoracolumbar. Can't talk this morning. The thoracic lumbar area. On your clinical findings, you may find that mom had a poor intake of folic acid in pregnancy. The sac-like cyst can contain meninges and spinal fluid. There can be flaccid paralysis of the lower extremities. There can be absence of deep tendon reflexes, decreased pain and touch response, and then there can be constant urinary dribbling. There can also be associated a cleft lip and palate, diaphragmatic hernia, transesophageal fistula. There can be bladder exstrophy or an imperforated anus. In the neonatal period, serial cranial ultrasounds are performed to watch for development of hydrocephaly if this condition had not shown up prenatally. Surgical resection and closure of the involved neural tubes are usually done with a week after birth, often shunting for hydrocephaly if needed. This is a multidisciplinary supportive case, and then also there's definite need of genitourinary management. Prognosis for these little ones: normal intelligence is seen in about 70% of them. There is a functional mobility issue, and that depends on the level and the degree of involvement. And prevention is folic acid supplementation for all females in childbearing age. And that amount would include 400 micrograms daily. Let's talk about myasthenia gravis, which is an autoimmune disorder that produces a mediated neuromuscular blockade or neuromuscular junction disorder. It starts with circulating receptor binding antibodies that decrease the number of available acetylcholine receptors. It is a non-hereditary condition. However, there are 3 rare presynaptic congenital forms that exist. Symptoms start at or close after birth and may persist. On exam, you may notice droopy eyes, extraocular muscle weakness, difficulty swallowing, muscle weakness of the neck flexor muscles, and limb girdle muscles. These kids can experience other autoimmune diseases such as lupus, thyroiditis, RA, or diabetes. Diagnostic studies that might be performed including the use of a short-acting cholinesterase inhibitor, and often may do an EMG, and this can be seen as more diagnostic than a muscle biopsy. Differential diagnoses include hypothyroidism, polymalacia, rheumatica, MS, progressive external ophthalmoplegia, Guillain-Barré, Mobius syndrome, and congenital ptosis, the eye drooping. Management is anticholinesterase therapy, and complications can include growth retardation from steroids and a cholinergic crisis. Okay, that's the end of Chapter 28, Part 3. Thank you.